Mr. Khumbula, you may go ahead.
Thank you so much, Dr. Verenga. Good morning, everyone. I hope you can hear me loud and clear. So just a quick exercise. I'm just assuming everyone on this platform at some point you're involved in obstetric ultrasound. So in the chat box, we need to see how many are performing transvaginal scans. So you can just post in the chat box if you perform transvaginal scans routinely in obstetric scans. Right, so my talk today will be on transvaginal scan, preterm birth screening, and surveillance. Right, so this will be the outline of my talk. So we're going to have an introduction on what preterm labor is, the Zimbabwean situation currently, then prevention mechanisms. Then I'll also talk about the protocol, which involves the technical aspects on how to measure cervical length, then also the common pitfalls. So I agree with Dr. Verenga that the current practice, we are still in the 70s with regards to the pregnant and non-pregnant imaging of the pelvis, particularly because of lack of skills, particularly because of lack of equipments. But we have no excuse because we are now in the modern day. It's better for you to have the skill or to know and lack the correct apparatus. So just to get a brief epidemiology of preterm birth. So about 130 million babies are born annually globally. And 4 million of these, they die in the first 4 hours of life, which is the neonatal period. And the main direct cause of these deaths is attributed to preterm birth, severe infections, and asphyxia. So our talk will focus more on the preterm birth rates, which are continuously rising despite the advances in knowledge of risk factors and mechanisms that are related to this preterm birth. So there are two reasons for this. One being that there is absence of an effective screening test to identify the women at risk, and also lack of an effective intervention to prevent this complication. So you find that in our protocol, for any pregnant woman at 20 weeks, we routinely check the cervix. That will be the mid-trimester scan when we do the anomaly scan. So this is the current situation in Zimbabwe. To say the perinatal mortality is at 29 per 1,000, and 34% is attributed to preterm birth. So currently, cervical stitch insertion is an obstetric intervention that is being practiced. And since the inception of the FMU, the preterm surveillance clinic since 2019 has identified a significant number of women who have got short cervix. Some have got cervical stitches inserted, which would then follow up. And amongst these are those with an existing history of preterm birth. So what is transvaginal scan? So this is the measurement of the cervical length through the vagina, and it identifies those women who would be at risk of preterm delivery because of the cervical lengths that we would detect at that instant. So this is our current data. So since 2019, we've been gathering data, and amongst the patients that we've seen, we've noted that about 667 have experienced preterm deliveries, and the majority of them being in the 31 to 35 weeks gestational age, which we feel we can improve through a well-structured and effective screening mechanism, which we hope to implement across our nation, so that we bring all those 10 to 15 weeks, 20 to 25 weeks preterm births to at least go beyond 36 weeks. That is the target. So amongst the patients that we've seen, the outcomes, you find that 74% have been alive. We also feel that's a percentage that we can also improve through all these this course that we've been going through, you find that there was golden experience and knowledge that was being shared. So if we implement these techniques, we hope to have at least beyond 5% of deaths attributed to preterm deliveries, stillbirths, etc. So any birth that occurs before 37 weeks of gestation is defined as preterm, and they can be subdivided according to the time of delivery. So if it's less than 28 weeks, that's extremely preterm. Then 28 to 30 weeks, that will be early. Then moderate, 31 to 33 weeks. Then mild, 34 to 36 weeks. Now, in predicting preterm births, so between 20 and 24 weeks, for those pregnancies that deliver at term, the mean length of the cervix is usually 34 millimeters. Then for those that have a cervical length less than 15 millimeters, 20% of these cases we have spontaneous preterm birth at less than 34 weeks. Then for those with less than 25 millimeters, this group we have 40% of cases that have spontaneous preterm birth less than 34 weeks. So the risk of preterm birth is inversely related to cervical length that we see between 20 and 24 weeks of pregnancy. So we therefore require a model whereby we combine the cervical length and obstetric history. So the obstetric history will now include those who would have had previous preterm births and those who would have short cervical length at the time of scan. So this will improve the sensitivity of the screening and lead to decreased preterm births. So prevention of preterm births in women that would have a previous preterm birth. So cervical sacrilege will reduce the risk of birth before 34 weeks by about 25%. Then there are two options in the management of these patients. So first, when we do the 11 to 13 weeks and we determine that there are no major fetal abnormalities, so these women will be offered an elective sacrilege. Then secondly, there will be measurement of the cervical length every 2 weeks and placement of a suture if cervical length becomes less than 25 millimeters. Then for those that would be seen to have short cervix, they will also be offered progesterone from 20 to 34 weeks, which will reduce the risk of birth before 34 weeks. So at the preterm surveillance clinic at Salim Mugabe, we see these patients on Thursdays, and depending on the gestation, we'll rebook them and see them every 2 weeks, whereby we'll be checking for any changes. If the cervix is progressively shortening, then for those with the cervix that will be shortening, they are the ones that will be offered progesterone. Then for those that would have a stitch inserted, to also be monitoring the pre-stitch and post-stitch length, which we'll see in the following images. So yeah, I think I've talked about this slide. Then for twin pregnancies with short cervix, their rates of preterm before 34 weeks is higher. It's at 15% compared to 2% in the singletons. Then in both singleton and twin pregnancies, the rate of preterm birth is inversely related to cervical length at 20 to 24 weeks. Then the protocol that we currently use, so this is now important for you to take note. So you'd find that there is a practice currently whereby pregnant women are asked to drink maybe at least 1.5 liters or even more before they get their obstetric scans. Well, you'll be subjecting them to unnecessary torture, as you find in the images that will follow. So we require that the woman empties their bladder, and then they are placed in the dorsal lithotomy position. Then the probe is covered with a latex or condom. Then some gel will be smeared on the inside the condom and also on top of the condom. Then it is gently inserted into the vagina, directed in the anterior fornix. So some literature say you can ask the patient to insert on their own, or you can insert, but gentle insertion. And you insert on direct observation, meaning as you've been setting the probe, you should be checking your screen to see if you're not exerting any unnecessary pressure. So a sagittal view of the cervix is obtained, and the endocervical region is used as the guide to determine the true position of the internal os, which will limit the confusion with the lower segment of the uterus. Then electronic calipers are used to measure the linear distance between, you notice a triangular area of echogenicity at the external os and a V-shaped notch at the internal os. So pre-stitch and post-stitch lengths will be measured in those that would have a stitch inserted. Then as we check for the cervix, we also get to check the viability, because there is no point in continuously monitoring a stitch without confirming viability. So we also check if the fetal heart motion is positive. Then you also check the position of the placenta in excluding placenta previa. So this is all done transvaginally. And each examination should be performed over a period of 2 to 3 minutes. So you realize that if you limit the time, sometimes there may be some contractions which may give a shorter or maybe shorter measurement. Then this is important before anything else. Consent. So in our unit, we usually request verbal consent. And for the studies that we are currently performing, we also have the written consent. Then there's also need for a chaperone. So for the gentlemen, ensure that you have a chaperone. Also considering these global trends, you know, sometimes even if you're female, you may need a chaperone as well before performing this examination. Then infection control. So after the examination, ensure that you disinfect the probe to avoid cross-contamination. Sorry, we just lost connection on the screen sharing.
You lost your screen, Mr. Khumbula there. Bring your screen back.
Okay, just a moment.
While Mr. Khumbula is addressing the screen issue, I think there's one question which Dr. Bonga asked about whether what is happening at these two big hospitals can also extend to Chitungwiza. For sure, it should be able to extend to Chitungwiza, but I think one of the biggest challenge we are facing in trying to implement or to introduce subspecialty services in units, it is a shortage of human resources. Some hospitals, they will tell you they do not have personnel to dedicate to do certain things. So human resource shortage is one of the biggest issue which we are facing as we try to replicate the situation in some of the hospitals, central hospitals. So yeah, but obviously there is a need for all our hospitals to have fetal medicine services and to have neonatology services, because that's the only way our hospitals can deliver their mandate. You can't have a high-risk hospital without these services and win against both maternal and perinatal morbidity and mortality. It is impossible to do it. Please, you may continue, Mr. Khumbula.
All right, thank you, thank you. So I was talking about infection control to say, ensure that you disinfect the probes after examination. Then you also need to dispose the used condoms properly. Then transabdominal sonography, like I was saying, some are using transabdominal assessment to check the cervix. So this one fails to visualize the cervix in a high proportion of cases, in particular those with a short cervix. So there are images that will come in the next slide. So transpenally, the cervix can be also examined by placing a curvilinear probe sagittally between the labia majora. Right. So the image on the left, let me use a pointer. Right. The image on the left. So you realize that this is a full bladder, this is the cervix. So if the bladder is too full or too empty, that may give problems. If it's too full, it will forcefully elongate the cervix. So you forcefully reassure the patient that their cervix is long, then hours or days later, then they enter into a preterm delivery. So you realize that for this same patient, the image on the right, there's a yellow trace. So actually this cervix was even less than a centimeter after performing a transvaginal scan. So transabdominal ultrasound in assessing the cervix, highly unrecommended. And right, there's another image, transabdominal. So you may not get a clear representation of the cervix. Let me try to trace. All right. Right. So you realize that if you are to comment, well, I think, I don't know what kind of eyes one will be having, but it will be difficult.
Mr. Khumbula, I think we are losing you a little bit, probably.
Oh, okay, okay.
We are
the
losing
audio.
you a little bit. If you can draw closer to your device, please.
Okay, that's fine. Is it better now?
It's better.
All right, thank you. So I was saying transabdominal assessment of the cervix. Well, the image on the screen, you realize that you won't get a clear representation to say, is this cervix open? Is it closed? Hence, our recommendation for us to perform transvaginal assessment. So this is one image of a patient who was at 34 weeks. Everything is okay. They don't feel any pain. However, performing a transvaginal scan, we now we discovered that the cervix was even shorter. It was at 7.7 millimeters, and there was some funneling, which was not detected transabdominally. So in predicting preterm births, sonographic measurements of the cervix length are useful in those asymptomatic women who would have a previous history of a preterm delivery, and those with uterine abnormalities like unicornuate uterus. The cervix length should be measured every 2 weeks between 14 and 24 weeks of pregnancy. So in asymptomatic women, we also perform these TVS scans, and this should be carried out routinely at the time of the mid-trimester scan, 20 to 24 weeks anomaly scan. Then you perform your transvaginal scan in trying to predict the risk of preterm delivery. Right. So the following groups of patients are the ones that are at increased risk of spontaneous preterm delivery, and they should be offered appointment in the preterm surveillance clinic. So those who would have experienced pre-prom or spontaneous preterm delivery at 16 to 36 weeks, then those with history of sacrilege or progesterone in previous pregnancies, despite them having a term delivery. And also those who would have a sacrilege in situ. So we need to monitor this sacrilege because there are also cases of sacrilege failure. Then also those with congenital uterine anomalies. So in predicting delivery at term, transvaginal scans can also be performed in those who would have an elective C-section. And we measure their cervical length at 37 weeks, and this will give a picture in trying to reach a decision whether to carry out the delivery at 37 to 38 weeks or delay it a bit depending on the cervix length. Then in women that would be undergoing induction of labor, the pre-induction cervical length will give a very important prediction of the induction to delivery interval and the likelihood of vaginal or cesarean section delivery. Right, so that image just shows a very long cervix, which was assessed transvaginally. We don't see the bladder anyway. Then what you need to be mindful of are the following. So first, you need to ensure that the anterior aspect of the cervix and also the posterior wall, they're of almost equal lengths. Then the bladder should be emptied. So if the bladder is partially full or even over full, that may forcefully elongate the cervix length. Then this was a transvaginal scan image performed at, performed at 17 weeks, and there was already bulging of membranes beyond the internal os. So these are the kind of images that will inform the caring obstetrician or the obstetric teams, the midwives, of the status of the cervix in a bid to lower down preterm births. Then this was another image. It's another image showing a very short cervix. Then for those who would have cervical stitch inserted, we also assess post-stitch insertion to see if the stitch would have been correctly placed. So in the image, you notice that these echogenic structures are the knots of the stitch, and you can see one is even in the amniotic cavity. Then the cervix was even short. So people may continue with their pregnancy saying the stitch is in situ, is correctly placed without any assessment. So this is why there is need for us to continuously monitor these stitch post insertion. Then the images on the screen now, they just show us the correct measurement and also assessment of those who would have their stitch inserted. So the one on the left upper corner just shows how to measure the cervix. So you need to first measure the length of the whole cervix. Then you also determine the sacrilege stitches, which should appear as echogenic structures, is highlighted on the image on the right upper quadrant of this screen. So from there, you now measure the length from the internal os to the diagonal line joining the two stitches. That will be the pre-stitch length. Then you also measure the post-stitch length, which would be the distance from the diagonal line from the stitch to the external os. Right, so the common pitfalls, so if you scan on a full bladder, that will forcefully elongate the bladder and you won't get the typical images that will allow you to give a precise measurement of the cervix. Then if you put too much pressure on the anterior cervix, again, this will also affect the measurement. You will falsely shorten or falsely elongate. Right. So with these words, here ends my report. So if there are any questions, you can drop them in the chat box, then we'll respond to them. Right, over to you, Dr. Vereng.
Thank you so much, Mr. Khumbula. Like Mr. Khumbula said, if there are any questions, let's drop them in the chat box so that he could respond to them during the next talk. I think we should all agree that we need to change practice. No one is going to come and tell you to change. This is the right platform to tell each other that we need to change our practice. Those who are still assessing women transabdominally for their cervical length, we need to move away from that. Of course, if the woman refuses to consent, you have to make it clear to them that the method they have agreed to be assessed with is one of the most inaccurate methods which may falsify the cervical length. But we need to change our practice. We can't be stuck in 1970s because no one is going to come and change us. It is ourselves who determine that this practice is archaic. No woman who is a modern woman who has an iPhone 15, I don't know where the iPhones are now, deserves to be examined this way if they have a gynecological problem. Neither they have an obstetric bleed. The best they can be done is to be checked transabdominally, and they are falsely reassured that you are okay when their cervix is almost popping out. So it is this kind of practice that we have to change, and it is up to us to change because we are the practitioners, we are the clinicians, we are the ones who examine